Hey, good afternoon, everyone, and welcome to our webinar titled Evaluation and Behavior Management of Severe Self-Injurious Behaviors with our guest speakers, Todd Kopelman and Mary Roberts. And this is brought to you by the University of Iowa Division of Child and Community Health, Child Health Specialty Clinics, and the Regional Autism Assistance Program. This webinar is part of a series for our Iowa Autism Learning Community. My name is Rochelle Swanson-Holm, and I am one of the organizers and will be moderating the session today along with Sharon Rettinger, who's our Family Navigator Network Coordinator for Child Health Specialty Clinics. This session will be recorded, and a link to that recording will be provided in a follow-up email. Any questions you have will be answered following the presentation. And if we don't have time for all the questions, we can certainly email you with the answers after the presentation. You are free to type in your questions into the question box throughout the presentation, and those then again will be answered in the final minutes of our time together. Continuing medical education credits, nursing CEs, and others wishing CE credit will be available for those attending this live session. So please stay on until the end of the session for further instructions on how to obtain those credits. Again, welcome, and I'm really excited to introduce our presenters today. Mary Roberts works as a behavioral health consultant and is the Autism Center Coordinator at the University of Iowa Hospitals and Clinics, and she is also a parent of 2 young adults with significant autism. She is the co-founder and president of the Village Community, a 501c3 disability advocacy and service organization, and she serves on multiple state advocacy boards, including the Olmsted Task Force and the Autism Society of Iowa. Todd Kopelman, Dr. Todd Kopelman, who is also a board certified behavior analyst and an associate professor in the Department of Psychiatry at the University of Iowa Hospitals and Clinics. Dr. Kopelman serves as the co-director of the hospital's Autism Center. His clinical area of focus include the assessment of autism in children and adults, and in the evaluation and treatment of severe challenging behaviors. He also regularly provides behavioral consultation in school settings. Dr. Kopelman has served as a project coordinator on 3 federally funded studies evaluating the use of telehealth to conduct behavioral evaluations and treatments with young children with autism who engage in challenging behaviors. He co-teaches a graduate seminar on autism, and he is the former president of the Autism Society of Iowa. Again, following the presentation, please stay on the webinar or line for further instructions to receive your continuing education credits. Mary and Todd, thank you again for presenting today, and we will begin.
Sounds great. Well, thank you. Very nice to be here this afternoon over the noon hour, and it's always wonderful to have the opportunity to present with Mary. So looking forward to this, and thanks to everyone for choosing to spend some time with us. So Mary is going to be going through the slides. She has control of them, so if you hear me saying next a lot, that's why. So we're going to go through this pretty quickly, but we don't have any disclosures. I wanted to start with that. A couple other things. We're not able to comment in great detail anyway about specific cases or situations. We're very happy with the time at the end to answer general questions and then to follow up as needed. And then just one other thing, we will be showing a few graphic images. It's nothing rated R or anything like that, but we're going to show some examples of self-injurious behavior. So I just wanted to make people aware of that, since that's the focus of our presentation today. Also wanted to thank some of our colleagues here at the hospital, Dr. O'Brien in pediatrics, and Dr. Cowers and Tate in psychiatry for their contributions. As we'll talk about, self-injury and autism covers a lot of different disciplines, and so we try to pull on as many resources as we have. So what we're hoping to do in the next 45 minutes or so, this might be way too ambitious, but the learning objectives are hopefully to increase your familiarity with what self-injury can look like in the ASD population and how commonly it occurs, understand some common risk factors for self-injurious behavior and some potential causes when those behaviors do occur as far as longer-term outcomes. And then to increase your understanding or knowledge of behavioral assessments and treatments of self-injury. And then finally, to appreciate the real value and importance, and this is to me the most important point of all, of an interdisciplinary approach. And I think that will be highlighted when Mary talks about a very personal case example that she's lived. Okay, so with that, we'll go ahead and get started. So next slide. So just wanted to start with a definition of what self-injury is and what it's not, what we're talking about here. So this is the best definition I found. Self-injurious behavior refers to a set or class of behaviors that an individual might inflict upon herself or himself that tends to lead to physical injury and in particular tissue damage. So self-injury often, not always, but usually consists of forceful, intense, and I'll talk about this in a minute again, repetitive contact that an individual is incurring upon themselves in one or more specific body sites. Not always, but oftentimes self-injury is highly repetitive in nature. So an individual could engage in self-injury infrequently, once every week, once every month, or even less than that. But the type of self-injury we're going to be talking about today tends to occur more frequently. So it might be multiple hits per minute, up to thousands of times a day. And the intensity can vary, and we'll talk about that a little bit later. I do want to distinguish the type of self-injury we're going to be focused on in the autism population from other also concerning forms of self-injury that we're not going to focus as much on today. So this self-injury is different from, a patient maybe who's receiving mental health or psychiatric care who has suicide attempts, or there are also some forms of what we call non-suicidal self-injurious behavior that might be seen in other conditions. So some individuals, and you may be well aware of this, might engage in repetitive cutting behaviors or burning themselves, binge eating, purging, substance abuse, smoking, alcohol abuse. Those are all forms of self-injurious behavior, but they're distinct from what we'll be focusing on today. So what can self-injury look like? It can take a lot of different forms. And Mary, you can just kind of quickly scroll through these, but the most common examples that I've seen clinically and read about are behaviors like head banging or hitting, biting oneself, scratching, arm banging, punching, dislocating joints, hair pulling, eye gouging, pica, which is the ingestion of non-edible items. I was just working with a patient at 11, so about an hour ago, who engages in a lot of skin picking behaviors, and I have that listed here as well. These behaviors might occur in isolation. In other words, a person might just have one of these, what we call topographies or forms of behavior, or somebody could engage in multiple types of self-injurious behavior. That's not uncommon. Next slide. So what do we see as kind of consequences or results of self-injury? Probably not surprising, but we see, no pun intended since we're talking about autism, but a spectrum of outcomes. And I've tried to kind of list this from least to more severe in nature, but of course on a case-by-case basis that might vary. But it's not uncommon for a parent or caregiver to tell me that their child or their adult child is bruising themselves or has scars as a result of their self-injurious behavior. Concussions can certainly occur, especially when somebody, for example, is hitting their head on a hard object like a wall or a floor, or hitting themselves with their fist in their head. Bowel obstructions can occur, dental and eye trauma. I've had a couple patients unfortunately lose vision permanently as a result of self-injurious behavior. And in rare instances, so I don't want to talk this up by any means, but it can occur, significant injury to oneself, including death. Other consequences that we see just on a kind of a practical level, or thinking about systems of care. If somebody is engaging in intense or frequent self-injury, it might result in frequent visits to outpatient clinics, to the ER, hospitalizations, and in more significant cases of self-injury, again, this isn't something that occurs often, but it does occur. The patient may need surgery. We may need restrictive behavioral treatments like holds or restraints, just from the sense of maintaining their safety. And then, unfortunately, reduced learning opportunities at school. If this is a behavior of concern, that individual may not be able to participate as much in the general education setting. And then social isolation, fewer social opportunities to engage with friends or peers. And in some cases, I've seen this reduce housing opportunities. If it's an individual with autism who is, for example, going to be in a residential facility, there are many that will not accept that individual because of the severity of their behavior. And then this goes almost without saying, but high reported levels of caregiver stress are associated with severe self-injury. Not to look at you, Mary, but you'll be talking about this personally in a few minutes. It's always funny when we do research on these kind of obvious things, but yes, if you have a child who's banging their head hundreds of times a day, shocking, right? That parents report that it's stressful. How often does this occur? It's more difficult to measure this actually than it seems like it should, just because there are different definitions of what self-injury occurs. And if we're measuring it at one point in time in a person's life versus at the time that they're asked to answer the questionnaire versus across the lifespan. The best estimates I've seen is that on average, about 50%, so 1/2 of individuals with autism engage in one of the types of self-injury I described at some point in their life. If we're going to look at right now, it's about 1/4. And both of those I think are really high. And to put that in perspective, self-injury occurs at higher rates in the autism population than almost any other subgroup or population that might be studied. So higher rates in the autism population than in the general intellectual disability population, or individuals who don't have autism but have communication difficulties, visual impairment, seizures, and certainly then the quote-unquote typically developing population, those without identified developmental or psychiatric concerns. And then a final point here is that oftentimes, not always, but oftentimes these behaviors are what we call chronic, meaning especially if they occur early in life, they tend to persist. They don't just go away on their own unless that person gets appropriate types of treatment. And there's been longitudinal research to demonstrate that. There are some what I would call general risk factors that have been identified through research that we feel like can make an individual who has been diagnosed with autism, put them at less or greater risk for engaging in self-injury. But I do want to say this somewhat cautiously. There's still a lot of unknowns and a lot of research that needs to occur in this area. So yeah, next slide. So these are the risk factors that I've seen in the research. So more severe symptoms of autism tend to be associated with higher rates of self-injurious behavior. And that IS in parentheses is just one of the symptoms, which is insistence on sameness. So if a child really gets upset when parts of their routine or their environment are disrupted, you can't go to school the same way every day because of traffic construction, they get really upset, or they can't have the same fork because it went missing, it's dirty, whatever. That type of behavior where they get very agitated, that's been associated with higher rates of self-injury. Repetitive motor behaviors have been associated with self-injury, and then sensory behaviors. So children who have higher rates of sensory sensitivities or underreactions, what we call hyposensitivity. So if you're working with a child, a patient, and the parent reports they don't seem to show a lot of pain, when they hurt themselves, then that has been linked with higher rates of self-injury as well. The degree of intellectual disability is also one of the things that's been looked at. So if somebody has more significant cognitive concerns, that's associated with higher rates of self-injury. Similarly with communication difficulties and social skills difficulties. Sleep disturbances, this is one of those again where it probably seems pretty obvious, but if somebody is chronically not sleeping well, they are at higher risk for engaging in self-injurious behavior. And then early history of stereotyped or repetitive motor movements and early history of self-injurious behavior. So especially if a child at the age of 12 months, 18 months, even up to 3 years or earlier is engaging in these behaviors, unfortunately that suggests that they're higher risk later on in life for continuing to engage in self-injurious behavior. So with that in mind, that background, we're going to move next to talking about the evaluation and treatment of self-injury. And so I tried to put this, oh, you can go back, Mary, I'm sorry, in as few words as possible, but the first step is to try and understand why the behavior is happening and then treat it. We can't treat unless we understand. And that, again, probably seems obvious to everyone who's listening, but it's really important to highlight that assessment is a critical first step. So there are some myths, I would say, for lack of a better term, things that I hear, and I know Mary has heard too, about self-injury that I just want to quickly dispel. So sometimes I think we're overly dismissive, you know, as professionals. And I've heard people say this, oh, well, that's because they have autism. That's why that child is banging his head or biting his arm. And then you don't think anything else of it. And while self-injury is associated with autism, it's not part of autism, and we shouldn't dismiss it. In the same way that if somebody is aggressive towards others, that we would probably want to quickly address that. If they're aggressive basically towards themselves, in other words, engaging in self-injury, we don't want to overlook it or dismiss it. And then I've heard two different things. All self-injury is due to biomedical issues, or biomedical issues do not cause self-injurious behavior. And both of those are not quite accurate. And we'll talk about that in just a few minutes. If you ignore self-injury, it'll go away. Again, the research suggests that's not the case, at least all of the time, that children who engage in self-injury often develop into teenagers and then adults with self-injury unless they're getting, you know, the right kind of treatment. And then all self-injury is just a form of communication. I think many forms of self-injury, many times when we see it, somebody is communicating something, but that's not the case 100% of the time. All right, next slide. So this is something that I borrowed from one of my colleagues, Dr. Tate, who is a psychiatrist at the university. And this has been developed over a few years as we just try and think about why a person represented here with a stick figure might engage in self-injury. So the first set of bubbles there are more medical or psychiatric reasons. And we'll go through these one at a time. But there are some genetic syndromes or what we call behavioral phenotypes that put somebody at increased risk of engaging in self-injury. So that's one reason, one possible reason. I have a physical illness. I'm not feeling good. That's another reason that some individuals with autism or other developmental disorders may start to engage in SIB or self-injurious behaviors. Side effects to medications, psychiatric medications or other medications. If you're not feeling good again, but it's in response to a medication you've been given maybe for something else, then we might start to see some self-injurious behavior emerge. Or it's the psychiatric illness itself. Then thinking about more kind of what I do as a psychologist, if you want to click again, the ones in green are more environmental reasons or factors that might be associated with self-injury. I'm put in a setting where I don't understand what the expectations are. I don't have the right kind of skills, and I'm really agitated or frustrated. So I might start to engage in self-injury. Or it could be that I want something that's called a tangible purpose or function. I don't have a better way to express that I want it, so I bite myself or bang my head because I'm really excited or frustrated. The opposite, I don't want that. You know, in school, maybe a child with autism is presented with a demand, like doing some math work. And that's their way of communicating, no, thank you. I do not want to do this. Pay attention to me. I want a lot of attention. And again, I don't know how to communicate more appropriately. So I might bite myself or engage in another type of self-injury. And then what we call non-social functions. It feels really good when I hurt myself. It's releasing some endorphins, for example. Or I'm not feeling good at all. I have a headache and I can't tell you I have a headache, so I start to bang my head, would be another example of what we call a non-social or automatic purpose. So this is really an important slide in this talk, because what I'm hopefully am going to communicate is self-injury could occur for one of these reasons and one alone, or it could occur for multiple reasons: environmental, medical, psychiatric. And so we don't want to make any assumptions before we move to treatment. So we have to think about all of these possible reasons why somebody might be hurting themselves and then treat accordingly. All right, next slide. So thinking quickly about the psychiatric piece. We know that there are increased rates of psychiatric disorders in persons with autism and in persons with intellectual disabilities, around 50%, it's estimated. So what is the relationship between self-injury and psychiatric illnesses? And Mary can press it one more time. There is this idea of a behavioral equivalence. In other words, the self-injury could be an unusual presentation of that psychiatric disorder. So somebody, for example, with autism who cannot communicate very well, but maybe they're severely depressed. They can't tell you, hey, I'm feeling really sad. I'm not doing things I used to do. I'm not eating as much. I'm not sleeping as well. You might start to see symptoms of depression, though, in unusual ways. And the self-injury could be one red flag that suggests depression. The more severe, oh, I'm sorry, if you could go back just for a second, Mary, I apologize. More severe behaviors are associated with more psychiatric comorbidities. And there is, based on some research, a pretty strong association between depression, anxiety, and challenging behaviors in the ASD population. So we don't want to overlook the possibility that there's an underlying psychiatric concern when we see self-injury in somebody who maybe is not the best reporter related to their diagnosis of autism or ID. Now I'm ready for the next slide, sorry. Physical illness. This is, again, one that's probably more obvious or apparent, and there certainly have been many studies that have shown that when somebody is engaging in severe self-injurious behavior, it could be secondary to another medical condition that we haven't identified, or, as I mentioned earlier, a side effect of a medication. Important to keep in mind that some individuals with autism may not manifest or show pain or physical discomfort in the same way that we kind of typically expect. Just as an example, I've worked with a few parents over the years who have given me examples of their child holding their hand, accidentally over a stove or a fire at a campfire, and they're not saying I'm hurt, or they're not crying, but they may later on show self-injurious behavior because they can't communicate in a more effective manner. They may not even be able to fully understand the linkage between the physiological condition and why they're engaging in that behavior. So really important to look for sudden changes in onset of self-injury that may suggest that there's an underlying medical cause. I mean, you can keep going, Mary. This is an important point just to think about, and we've touched upon it before. It's called diagnostic overshadowing. And I talked about that earlier, where we just assume because somebody has a diagnosis like autism, that that's okay. They're hurting themselves because she has autism, and that's just part of who she is. We do not want to overlook other reasons for it, including these medical explanations. There are a lot of possible underlying health conditions that could be related to self-injurious behavior. This is not an exhaustive list here, but these are just some of the more common areas that I've seen clinically and that I've seen reports about. But GI concerns, infections, seizures, dental. I had worked with a child, this is several years ago now, a child with an intellectual disability and autism. He was nonverbal, and he did have a history of self-injurious behavior, but the rate of the self-injury was on the scale of a few times a week. And then all of a sudden it went off the charts, which is not a clinical term, but we're talking hundreds of times a day. He was hitting himself in the jaw. And so we started with kind of looking at medical reasons given that sudden change, and he did have an impacted tooth. He could not communicate that, but it was a dental issue. We got it addressed, and the self-injury didn't go away completely but it went back to baseline, which was much lower rates. So I always think about that child when I think about dental. Sleep disturbances, I mentioned that earlier, pneumonia, fractures, and then certainly hearing and visual impairments too. Again, other reasons medically could cause self-injury as well. There are genetic disorders, a whole host of genetic disorders that are associated with higher rates of self-injurious behavior. This is not a complete list either, but these are some of the more common ones that have been identified as if you're seeing a patient or have a child or loved one with one of these disorders, then that individual is at increased risk compared to the general population of engaging in self-injury. And I starred the one at the bottom because I just want to highlight Lesch-Nyhan disorder, and you can go to the next slide, Mary. I've worked with a few individuals with Lesch-Nyhan. It's a rarer disorder, but it certainly occurs. And so Lesch-Nyhan, if you're not familiar with it, it's caused by a specific gene, the HPRT1 gene. It's an X-linked recessive inherited gene. And it's a syndrome or disorder that's characterized by overproduction of uric acid. So think about like severe gout, but it causes arthritis and frequently kidney and bladder stones. Not always, but cognitive disorders can be associated with it. I've worked with some individuals with Lesch-Nyhan who have typical or normal cognitive functioning. And my understanding, and I was just looking at this before this talk, is that there's still not a cure, unfortunately, for Lesch-Nyhan. So the focus is more on treating the underlying symptoms. So self-injury, unfortunately, is very common. 85% or more of individuals with Lesch-Nyhan will engage in self-injurious behavior, and it often emerges very early in life, before the age of 3. And it is, unfortunately, a very brutal diagnosis. Individuals with Lesch-Nyhan will oftentimes not be able to prevent themselves from hurting themselves. So the most common forms of self-injury are biting lips and tongues, including biting those body parts off, and severe head banging. And next slide. This is just a picture of some of the self-injury that can occur in a person with Lesch-Nyhan. So you'll often see severe bruising, unfortunately, around their lips and then their fingers as well. It's just a horrible disorder, unfortunately. So moving on from kind of medical and psychiatric underlying causes, there can be behavioral causes as well. And Mary and I could talk about this, for a long period of time. Because of time, this is going to be much abbreviated. But when we're thinking about behavioral or environmental causes, we think about this ABC model, which has been around for a while. And that you may be familiar with it, but what are the antecedents and the consequences surrounding a behavior? So we try and look very carefully with self-injury is there anything going on in that person's environment right before they engage in self-injury? And are there any consequences associated with it that might, what we call, reinforce or maintain that behavior? Next slide. And we can skip that part about setting events. So we try and kind of put people in categories. It's not always that neat and clean, but just to kind of think about the environment very broadly. A person might engage in self-injury because of access to attention. If you think about that picture with the stick figure with the bubbles, that was one of them. I'm acting out to get a response from others, and I've realized if I hurt myself, my mom or dad, because they love me, or my teacher or somebody else is going to come in very quickly and give me attention. I've certainly seen the individuals who engage in self-injurious behavior because they want something. Could be a tablet, watch a video, it could be food, it could be a favorite, activity like going outside and swinging or playing. and they don't know how else to get that, so they start to bang their head. And again, as I mentioned briefly earlier, somebody might engage in self-injury to avoid or escape something that's aversive to them. They don't want to do schoolwork. They don't want to do chores at home. They don't want to get out of bed in the morning, and they've been told it's time to. And so they might start to engage in these types of behaviors. Yeah. And then there's this other category of automatic reinforcement. And this certainly can occur in individuals who are engaging in self-injury, where they're doing it because either it feels good, and this is more often observed under what we call low stimulation conditions, like somebody with a visual impairment who starts to poke or rub at their eye. Or it could be automatic negative reinforcement, and that's often related to some of those health conditions that I was talking about earlier. Maybe they have an ear infection or a severe headache or tooth pain, and so they're trying to attenuate or get rid of that discomfort or pain, so they start to engage in self-injurious behavior as a result. So when we're trying to figure out why, from an environmental standpoint, these behaviors might occur, behavioral psychologists, therapists often will do an assessment, and there's a specific type of assessment. Again, because of time, I'm not going to go into it really in any detail, but it's called a functional analysis or a functional assessment. And that often looks like a little experiment where we would systematically change what's going on in that person's environment. For example, we would withhold attention, tell mom and dad not to talk to your child for 5 minutes, and then we would see what happens. Do they engage in self-injury or not? We might say, you can't have your favorite toy or activity for 5 minutes. Do they start to then engage in self-injury when they're provided with it? Or we might present demands that are appropriate for that person's developmental level, schoolwork or picking up toys or anything like that. And again, we're looking for patterns. We would repeat each of these conditions several times to say, okay, do we see a pattern where this is when the self-injury is most likely to occur? If we do, then it suggests that it may be occurring for that purpose or function. And you can go on to, Mary, the next slide. This is an old study. Obviously, it's from 1994, probably older than some of the people listening, but it's considered a classic study in our field of behavior analysis, where they looked at what are the different functions of self-injurious behavior. And you can see that automatic, and I think, Mary, if you click, it'll highlight this. Automatic functions do occur in about 28% of the cases, but in over half the cases, there was either a negative reinforcement function or a positive reinforcement function. So 31% of the time, escape, 26% of the time, attention or tangible, 7% of the time it was multiple reasons, and 8% of the time there was not a clear function identified. So the take home from this, and this has been replicated since 1994, of course, is that self-injury often does occur for automatic reasons. Think about those health conditions, but it also often occurs for environmental reasons too. Next slide. So again, I'm going to go through this fairly quickly because of time, but from a behavioral standpoint, once we've identified the purpose or the function of the behavior, what we do next is we move to treatment. And there are some broad categories of treatment for self-injury. The first one you see here is called extinction. I'm guessing many of you have heard that term before, extinction of behavior. Basically it means we're not going to reinforce that self-injury any longer. So if we learn that somebody is most likely to act out for a tangible function, to get an iPad, for example, we would want to make sure in the future that we do not give them the iPad following any self-injurious behavior. That's what extinction would be. You're not going to get what's reinforcing the behavior following that problematic behavior anymore. And then next slide. So let me show you what extinction might look like, and just, you can go ahead and click, Mary. There's a lot of clicks here, I apologize. So the antecedent might be a child wants Thomas the Tank Engine and they hurt themselves. And usually in the baseline before we start treatment, maybe they would get Thomas. And that's a very common thing that somebody who loves their child might do. You don't want to see them hurt themselves. You know they want Thomas. So after they hurt themselves once, you give them Thomas. Unfortunately, from a behavioral standpoint, that might only strengthen the behavior. So when we move to treatment, let's say the child still wants Thomas, they're not going to get it if they hurt themselves. So if they hurt themselves, no Thomas. Instead, what we're going to move to is more of a reinforcement or communication-based treatment. And I'll talk about that in a minute. So yeah, reinforcement-based treatments. With reinforcement, we're just going to provide a consequence, something that that child wants, contingent on not engaging in the self-injury anymore, and at the same time, engaging in a more desirable behavior typically. And one of the more common treatments that we do focuses on communication, really teaching a child a more appropriate way they can communicate for what he or she wants instead of the self-injury. Go ahead, Mary. So going back to the same example, the baseline is going to look the same. If the child engages in self-injury, they might have gotten Thomas on occasion. With a reinforcement treatment, they want Thomas. What they're going to have to do is communicate. All sorts of ways we might focus on communication. In this example, the child's pushing what's called a micro switch, which might be programmed to say, I want Thomas, please. If they hurt themselves, they don't get Thomas. That's that one column. But if they press the switch and they don't hurt themselves, we're going to say, great job. Here's your Thomas toy. So we're reinforcing good communication instead. And there's a lot of research to show that that can be a very powerful form of treatment. All right, next slide. And then the final general category we think about is punishment-based strategies. And you may have a thought in your mind of what punishment looks like. It's probably not necessarily what I'm thinking about. We don't want to hurt anybody. We're not talking about spanking or slapping typically or anything like that. A punisher from a behavioral definition is you apply or withdraw a consequence when a self-injury occurs in order to decrease the likelihood that that self-injury occurs in the future. And punishment is very individualized. What I find punishing, you may not find punishing. To me, one of the biggest punishers is having to do the dishwasher. So I try and use as few dishes as possible, but I've met people who like using their dishwasher and find it relaxing. So it may not be a punisher to them to tell them they have to do dishes. It's very individualized. Next slide. So again, this example, we know what baseline looks like before treatment. With a punishment-based treatment, and you can just go through these quickly, Mary. We might have that, oh, one back, sorry. We might have the child pick up laundry, fold towels, if that's something that they don't like to do following self-injurious behavior. For me, that would be an example of a punisher as well. You know, if I do something that you don't want me to do, just throw a bunch of towels in front of me, and over time, hopefully I'm gonna learn, oh, I shouldn't do that behavior anymore. So that would be what punishment might look like for a child. All right, next slide. So there are a lot of options we have in our field of applied behavior analysis, some of which are less intrusive and some of which are more intrusive as far as the effort and just I think too from an ethical standpoint, whether or not we want to utilize those treatments. And we should be very thoughtful and think about the potential consequences of the self-injury, you know, what could result as far as injury to that person and how severe or immediate it could be when we're thinking about selection of treatment. And Mary, I think you can just kind of click again. I think there's a few more. So these are just examples. And again, I do not have time, but I'm always happy to talk later about a menu of treatments from least intrusive to these more intrusive types of treatment. Now, what the research has shown, oh yeah, Mary, you were correct, you can skip ahead. As far as what actually works from a behavioral standpoint, what tends unfortunately to be least effective, especially with these severe cases, is a reinforcement or an extinction only approach. So unfortunately, what does tend to work and be most effective, and again, this is for more severe cases, is a combination of reinforcement and punishment that tends to work the best. So I know, and I personally do not like to use punishers. We always try and use in our field reinforcement first, but the literature does suggest that sometimes reinforcement alone is just not sufficient for those more severe cases of self-injury. All right. Medications real quick, and I'll go through this super quick because this is not my area, but this is from my colleagues in psychiatry. There is no single medication that's specific to self-injurious behavior. There are classes of medications that have been found to be helpful in the area of autism and self-injury, and atypical antipsychotics are considered to be the frontline medication treatment. And Mary can go through again. So this is an example, or this is a list rather, I should say, of the types of antipsychotic medications that have been FDA approved and might be prescribed for self-injurious behavior. And you're probably familiar with many of these, especially Risperdal or Risperidone is probably one of the more commonly that's used. All right, next slide. There are other medications, classes of medication that might be recommended as well, depending on why we think the self-injury is occurring. So if we feel like it might be related to severe anxiety or those rigid behaviors, which I talked about earlier, are strongly associated with self-injury in the ASD population, and SSRI might be recommended. If it seems to be related to ADHD and impulsivity, a stimulant might be recommended, or a non-stimulant medication as well. So again, obviously it's really important to do an individual assessment of that person to understand what might be driving the self-injury, so the medications are targeted as best we can. And then there are other medications as well, mood stabilizers, anti-epileptic medications, beta blockers, or specific medications, naltrexone, for those repetitive and rigid behaviors that have been shown to have some success. All right, and so with that, I'm going to turn things over to Mary, and she's going to talk about a case study.
Can you hear me okay, Todd?
Yes, I can. Yep.
Great. So thank you for that information. I'm going to quickly present a case study, and we'll leave time for questions at the end. As Rochelle had mentioned in the beginning, I'm the parent of 2 young adults with significant autism. This is my son, Jacob. Jacob's 25 years old. He's obviously aged out of the school system, and a couple friends of young adults with special needs and myself had started the Village community, which was also mentioned before. Part of the services we provide are rehabilitation. So Jacob was attending the Village full time. He had friends, he participated in Special Olympics. He was really a functional part of his community to the extent that his disability allowed. And he, most importantly, was happy. I really felt that he was having a good quality of life. Until 2017, as I had mentioned, he was very happy, no health concerns. I've had many people say, oh, I don't know how you do it with 2 significantly affected young adults. And my go-to answer was always like, well, at least they're physically healthy. I don't know parents, how they do it, who have to deal with health issues with their children. I did find out starting in the fall of 17, we were at a Special Olympics event, and Jacob started out of nowhere ripping off his shirt and punching himself in the sternum as hard as he could, to the point he was causing tissue damage. And that was a self-injurious behavior that I had never seen with him before, and that's something to keep in mind. His go-to is typically biting his hand. This is something that was completely new. So to me, there was a reason behind that. The whole following year, he really just deteriorated. Severe self-injurious behavior, which again was not his baseline. Emesis, sleep difficulties. He had significant muscle wasting, lost 35 pounds, and became completely homebound. Because of the level of the self-injurious behavior of unknown etiology at that time, we just couldn't have him around other people. It wasn't safe, so he was not able to attend his day program. And this is how he spent his day, on a couch with a one-to-one to keep him safe. And as you can see by his hand and the distressed look on his face, clearly we weren't succeeding. He was a pretty unhappy person for quite a long time. Here, this is kind of another example of, he wasn't tapping his sternum, he was punching himself as hard as he could until these red marks ultimately become bruising. Let's see, this is a video just as an example of different types of self-injury that he was engaging in, so hopefully this works. Stop. Stop. So that's one example, and here's another one. So just in that short clip, you can see multiple types of self-injury. Sorry, I must have attached that twice. But over the course of 3 years, and the behavior that you just saw in those videos, that wasn't intermittent. That was pretty much all day, every day. Went on for the better part of 3 years. So as Dr. Kopelman had mentioned, you know, caregiver tension and burnout is not a made-up thing. It's really challenging when you see somebody that you are responsible for in that level of distress and to not have the ability to fix it for them. These are just some of the specialists that Jacob saw trying to figure out what was going on. I was convinced that there was medical etiology for this since it came out of nowhere. This wasn't, you know, a type of self-injury that we had seen before in him, and that combined with the physiological aspects of the weight loss and the vomiting and things like that. We really had a hard time with diagnostic overshadowing, which Dr. Kopelman had mentioned, to the point that we had providers at Mayo Clinic saying that he was not regaining weight because he was stimming. And when he stims, he flaps his hands. He's done that since he was a child. I tried to explain that to them, but they were convinced that that was part of the issue. And as you can see, we really had a pretty comprehensive evaluation. The issue was it was broken up. We saw each of these specialists separately. And I don't know if you could tell in this picture, but if you look at the area under his rib cage, I mean, he had, compared to the earlier pictures, just wasted away to nothing. And, you know, he was sleeping or injuring himself, and that was his life. So we continued doing testing and visits with multiple specialists at 3 different hospitals for 2 years. And then finally, this summer, we had a 6-week inpatient stay at the med psych unit at the University of Iowa Hospitals and Clinics, and it was cohesive. It was multidisciplinary. I, as the parent, did not have to be the go-between to talk to the doctors. They talked to each other, which was fantastic. And those 6 weeks, I truly feel that he is now recovering. His weight is normalized. The self-injury that was going on all day, every day has been eliminated. And so, as Dr. Kopelman had mentioned earlier, that multidisciplinary approach with these folks who can't functionally communicate is so key. We really need to help communicate on their behalf. And that takes a team, and that includes the parent or caregiver, because we're the ones that are familiar with the nuances of their behavior and can help you as clinicians figure out what's going on, what's normal as baseline and what's not. This is something that I share. This picture breaks my heart, especially, you know, in seeing the other pictures from when he was healthy, the difference. And so just from a parent perspective, it was very challenging to get unfamiliar providers to look past autism and believe that Jacob's presentation was atypical from his baseline and the result of health issues. And despite my insistence, and Dr. Kopelman can back me up on this, I'm not one who sits back and waits. There were, you know, felt like half of my life was made up in phone calls to try to take care of this, and countless medical appointments. It took over a year to have him diagnosed and 3 years to receive required treatment. In the interim, his health and well-being was significantly compromised due to delay in appropriate intervention. And these last few years have been eye-opening as to the extreme deficits in the healthcare system to provide appropriate care to individuals like Jacob, and one of the most difficult and emotionally draining experiences I've had. I actually was diagnosed with PTSD as a result of dealing with this, and it's something that I wouldn't wish on my worst enemy. I literally felt every day like I was watching my child die. and injure himself while he's doing it because he didn't understand what was happening. In this picture, you can see just an extensive amount of self-injury. And again, that got to be his standard the last 3 years. And I cannot have this in more bold font. I just cannot stress this enough. I need to put it on t-shirts. Special needs individuals are entitled to the same level and quality of care as those who can functionally communicate their medical needs. And so, as Dr. Kopelman had mentioned, not all self-injury is communication, but please be sure you are doing the person justice by ruling that out, which sometimes, as you can see by Jacob's history, is easier said than done. But what is the alternative? You know, they continue to injure themselves. That can cause its own medical problems. You know, it's just something that really people need to trust their gut. And sorry, I thought we had another slide in there. I'm going to let Todd, do you want to do the wrap up?
Sure. Yeah, thank you,
Okay.
Mary, so much. I think that more powerfully summarized, you know, what we're trying to get at than anything else I have to share. But again, this is a very complex topic, you know, that we're trying to provide some information about in an hour. But really, the take-home points, I think, for clinicians, practitioners out there, are that it's really important when you're working with somebody with self-injury to consider it from different fronts. You know, consider the medical potential implications or causes, rather, environmental causes, and psychiatric conditions. And it could be just one of those things. It could be an interaction or multiple variables contributing to the presentation in front of you. From a behavioral standpoint, and this is again what I do, so this is why this is included, I do feel it's really important, teach communication skills to replace self-injury with what we call a functionally equivalent behavior. Help that individual get what they're looking for and that they're trying, you know, currently to get at through self-injury. Teach them a better way to get that want or need met. And that often can be very successful. As we've talked about a few times now, avoid diagnostic overshadowing. So do not just dismiss it as autism, and I'm sure none of you would, but I do see that sometimes, like, oh, that person's hurting themselves, they have autism, that's par for the course. And no, that's not an acceptable response. And then finally, again, we've talked about this as well, but I wanted to leave with this, and Mary, you can move to the next slide. We really, really, really need to think about this from an interdisciplinary standpoint. Silos are really good and helpful, and we see them all the time in Iowa, but they're better on farms, in my opinion, than in medical institutions or other care facilities. So it does take extra work sometimes, but it's really, really important for the well-being of individuals with autism who are engaging in self-injurious behavior. All right, so I think we have a few minutes left. I do have to run right at 1 o'clock, but Mary and I are available until then if there are any questions.
Well, Todd, Mary, I want to thank you very much for the information you shared today. It was a great opportunity to learn about self-injurious behaviors and treatment, and very informative. Thank you so much. And Mary, I really want to thank you for sharing your family story.
Sure.
It was just so powerful, and really appreciate the opportunity to hear firsthand from a parent that has that experience. So thank you.
Thank you. I appreciate the opportunity.
Yeah, thank you. And Sharon is fielding some questions for us in the question box, and I encourage anybody else to go ahead and type in any questions you might have. We have a few minutes before we share a little bit about the getting some continuing education credits. But Sharon, are you on?
Yes. Yes. So our first question is functional assessment. Can a therapist provide this assessment without a specific training in providing it?
Mary, is it okay if I jump in on that one? So I would strongly encourage training in understanding the functions of behavior before doing that type of assessment. So usually those are done by board certified behavior analysts, BCBAs. or psychologists or therapists who have gotten specific training in applied behavior analysis or ABA. Now, and I'll try and answer this as quickly as I can, and I'm very happy to follow up with that person separately. There's a continuum of ways to do a functional assessment. So on the easier end would be to do a questionnaire, and I would be comfortable with a therapist without a lot of background doing a function-based questionnaire. So there are a few out there that look at the motivation to engage in different types of behaviors, and you can use that to develop some initial hypotheses. But really the gold standard approach is the functional analysis, which I briefly described. And for a lot of reasons, you wouldn't want to do that unless you have training. You wouldn't want to set up a situation where you might start to see self-injurious behavior without understanding what it means or how to stop the assessment, for example, if the behavior persists.
Thank you. The next question is, it says, so there was a medical diagnosis for Jacob?
Yes, quite a few actually, and really kind of odd, strange things, mostly GI based, but the primary issue was something called eosinophilic esophagitis, which is interesting. You know, that's right where he was hitting himself, is where the esophagus goes down into the stomach. And bile gastritis. Jacob has pica, one of the issues that Dr. Kopelman mentioned earlier. And it turns out that all of these medical issues were due to a parasitic infection that he likely acquired through ingestion of you know, leaves or dirt or something outside, which obviously we don't allow him to do, but oftentimes where there's a will, there's a way. And unfortunately, you know, in the United States, parasitic infection in adults is not necessarily something that a lot of providers are comfortable or have experience treating. So it was really pretty complicated. But yes, we did finally get him diagnosed. It's a laundry list of diagnoses, but I truly feel like we're on the right path now. And I think that is reinforced by the fact that the self-injury has been eliminated and that the weight's now maintained.
And the next question is similar. It says, Mary, what was the diagnosis, which you've shared, for your son, and how was he treated for his concerns?
So it's interesting. They kind of had to go, you know, around the backside to figure this out. He responded well to the parasite treatment, but we found out from a rare disease doctor who, while he was inpatient, collaborated with his team on the inpatient unit, and he has worked internationally, so is, you know, very familiar with these issues, and you know, told the team and myself that the initial medication dosage was not sufficient. And so it was kind of backtracking and figuring out what issue was related to what problem and treat that. And, you know, it really, the 6 consecutive week stay was quite long, but absolutely was fantastic as far as, again, facilitating continuity of care.
Okay, and the next one, I'm not sure, but maybe it says, I would love to hear the questions that he's referring to. So,
Was that on the assessment maybe, or?
I wonder. It doesn't say that.
If that person could maybe send some follow-up information. I don't know if they're asking about the function-based rating scales, but I can send those out, you know, information about those. Again, that's a good first step. It's kind of a screening type approach to understanding the function of a behavior. Yeah.
Okay, it's Rochelle again, and again, thank you, Mary and Todd. And we just have 1 minute left, so I'm afraid if you have any other questions, we'll surely forward them to Mary and Todd and make sure you get the answers. But I did want to share that if you're a physician or a physician assistant or want to self-claim your continuing medical education credits and print your certificate, you'll be able to do so if you go to the UI College of Medicine CME portal, and you will receive an email about doing that. For nursing CEs or others wishing to receive any type of CE credit, please stay on the line and complete the survey that will be displayed, and/or you will be sent an email as well, and if you don't have time yet right after this session to complete the survey. But once you complete that survey, then I'll be checking the information online, and I'll be able to go ahead then and email you a certificate. Again, I want to thank everyone for participating today. We had a great turnout, and again, thanks to Mary and Todd. And I hope everyone has a nice day and a happy Thanksgiving to everyone.
Thank you.
Thank you very much. See you.
Bye-bye.